The second part of this lecture will focus on postpartum complications. Those can include postpartum hemorrhage, hypovolemic shock, thrombophlebitis, infections, mastitis, endometritis, wounds, urinary tract infections, and postpartum depression. Postpartum hemorrhage is one of the leading causes of deaths among postpartum clients, and a postpartum hemorrhage is considered to be blood loss that's over 500 milliliters after a vaginal delivery and over 1,000 milliliters after a cesarean section. Postpartum hemorrhage is categorized as either an early or late. So an early postpartum hemorrhage refers to a hemorrhage that occurs within the first 24 hours after birth, and a late one refers to a hemorrhage occurring after those 24 hours. The postpartum hemorrhage risk factors include being a multiple parity, a multi-fecal pregnancy, meaning twins or triplets, a macrosomic baby, a big baby, prolonged or precipitous labor, which means a very long labor or a very, very quick labor, a labor induction, vacuum or forceps assisted delivery, lacerations, delivering a stillbirth, having a placenta previa, use of certain medications like magnesium sulfate, and other mechanical factors such as a full bladder. In early postpartum hemorrhage, this is often caused by what we call uterine atony. So we know that uterine atony is the failure of the uterine muscles to contract properly, and thereby that inhibits the healing and the clotting of the blood vessels at the site of the placental attachment, and then the blood vessels continue to bleed until the uterine muscle contracts. Signs that you may be seeing uterine atony are a boggy or soft uterus, a fundus that is higher than what we expect it to be on palpation. So think about where the fundus kind of sits around the umbilicus in the first day or the delivery day and the first day or two after. If it were higher than that, or an excessive amount of lochia or bleeding. Nursing interventions we can do that if the fundus is not firm or what we call boggy, there are several things we can do to try to fix this problem. We can massage the uterus to help it to contract. We can press gently on the fundus to help express any blood clots that might be sitting in the uterus. And we can encourage the client to void, or we may need to actually put a catheter in them if they are not able to. Other things is we can administer medications like we talked about: Pitocin, Methergin, Hemabate, Cytotec, Ergovine. In the late postpartum hemorrhage, which is often caused by the subinvolution of the uterus because of retained placental fragments, then this is what prevents the uterus from contracting. So clots that develop around the retained fragments and hemorrhaging can occur days later when the clots are shed. So this would occur if the placenta was delivered, but parts of placental tissue were left behind. The uterus will start to involute as normal, but it's somewhere in that time, and it could be hours to days to weeks later, when the uterus recognizes that there are still placental tissue fragments left behind, it will stop involuting or not involute all the way or properly. And this is why it's considered a late postpartum hemorrhage. The practitioner is responsible for examining the placenta once it's delivered to make sure that it came out intact, not in pieces, not with any piece missing. Clients with placenta accreta, which we spoke about earlier in high-risk antepartum, or when providers attempt to extract the placenta prior to it being ready to have uterine wall separation, increases someone's risk of late postpartum hemorrhage because it's more than likely that pieces of that placental tissue will be left behind. Nursing interventions are to assess and manually express any placental fragments that are left behind. Surgical intervention may be necessary if you cannot get those out just by manual expression. You can do a dilatation and evacuation, which is where they dilate the cervix and go in with a suction and try to suck out any placental tissues that are remaining. Fundal massage, you can give medications like Pitocin previously mentioned, and that can help minimize the bleeding as well. Hypovolemic shock can occur, and this is a part of postpartum hemorrhage that can occur when and cause severe organ damage or even death if left unattended. So under normal circumstances, postpartum patient is able to withstand a certain amount of blood loss during that postpartum period due to the fact that they have increased blood volume during pregnancy. However, if it exceeds that, the patient is at risk of going into shock. Signs and symptoms of this would be tachycardia, which is often the first sign, blood pressure usually decreased or respiratory rates are increased, the skin becomes cool or pale and then cold and clammy, and clients may also be exhibiting anxiety or agitation or being restless as the blood loss will start to affect their brain. Interventions for this would include hypovolemic shock medications or IV replacement. So these clients will also require oxygen via face mask, ideally 8 to 10 milliliters, IV fluids, and possibly replacing of blood products. This is a very serious situation, and nurses must be prepared to assist because this is life-threatening. A thrombophlebitis is another risk or postpartum complication, which is a result of that venous stasis and the normal hypercoagulation state of the postpartum woman. An inflammation of the blood vessel wall in which a blood clot can form and then cause problems in the superficial or the deep veins of especially those lower extremities and pelvis. Predisposing risk factors for thrombophlebitis can be varicose veins, having previous clotting disorders, having a C-section or other surgery, diabetes, smoking, obesity, advanced maternal age, or patients who have prolonged sitting or standing. This can become life-threatening. The blood clot that develops in thrombophlebitis can lead to a life-threatening pulmonary embolism as a result of the clot detaching from the vein wall and blocking the pulmonary artery. This is why it's important for us to assess Hohmann sign, where we dorsal flex the foot to see if we can assess for any pain when we do so, as well as feeling for any warmth or significant area that is bigger on one calf or leg than the other, which might signify there's a blood clot there. Signs and symptoms of a pulmonary embolism may include dyspnea or chest pain. We need to monitor our postpartum patients for the development of thrombophlebitis, as this can turn into a pulmonary embolism. Nurses should assess for the presence of that hot, red, painful, or edematous area in the lower extremities or groin. An elevated temperature may also be present. And it is currently contraindicated to do the Hohmann sign to the point where you are dorsal flexing hard against the patient's foot, because you could dislodge that clot. So in contrast, what you would do is you would have the patient dorsal flex their foot themselves rather than you actually pushing on their foot, and asking them if they're experiencing any pain when doing so. And then as they have their foot in a flexed position, usually while they're laying down, you would come from behind their calves and legs and kind of feel for any warmth or area of edema. Infections are another complication to postpartum period, and these are accompanied by temperatures of 38 degrees Celsius or higher on 2 separate occasions when no other explanation can be responsible for the elevation of temperature. And remember, we talked about the milk coming in can elevate the temperature. Initially, right after birth can elevate the temperature. So we're just talking about things that we can't explain other than 2 different times of a high temperature. Postpartum clients should be carefully monitored for signs and symptoms of infection during this time. And common infections that can occur to our patients in these postpartum time is the mastitis, is an endometritis, are wound infections of either the C-section wound or the perineal wounds if we have lacerations or cuts, and urinary tract infections can be common as well. Mastitis, again, I'm not going to go over too much. We've talked about this a few times, but this is the one complication where the bacteria can get into the milk ducts and cause the milk ducts to not only block, but cause an infection in those, and that requires an antibiotic. And again, we talked about the signs and symptoms, the low-grade fever or the high fever, chills, general malaise, and redness around the infected area. Nursing interventions would be that we teach breastfeeding clients proper lactation and latching techniques. We stress that to feed infants regularly and allowing the breast to empty completely. And then treatment again would be antibiotic therapy and continuing to breastfeed or to pump the breasts, applying cold or warm compresses to ease the discomfort, and an analgesic as needed. In endometritis, this is an infection of the uterus characterized by the uterine subinvolution. It's an infection that causes abdominal cramps and purulent, foul-smelling lochia. This is caused by the bacteria that is not normally found or present in the uterus or the cervix, such as E. coli or group B strep. The risks are when we have manual removal of the placenta, and that would be if we had to go into the uterus to manually extract the placenta, or if we were manually pulling the placenta out of the uterus during a cesarean section. If there are multiple vaginal examinations done to the patient during labor, if she were a C-section, if she had premature rupture of membranes where they were ruptured for a good period of time, or if there were internal fetal or uterine monitoring devices used, which is also a portal to infection. Signs and symptoms of an endometritis would be cramping, foul-smelling lochia, fevers, chills, general malaise, and it could exhibit some tachycardia. Our interventions for this would be to collect blood cultures to identify the causative organism, whether it's the E. coli or the beta strep. And this is typically done with a white blood cell count, and we monitor those as well. And this can usually be treated with intravenous antibiotics and rest. In wounds, this could be the C-section or the lacerations of the perineum can occur. The infections can occur at these wound sites. Signs and symptoms of these would be redness, warmth, poor wound approximation, tenderness at the site, pain, and if left untreated, it could develop into fever and other symptoms of infections such as malaise. So nursing interventions in those cases were to be dressing changes with normal saline if we need to do that. We don't normally do dressing changes on a C-section scar, but if we are concerned that infection might be taking place, we could do that. We're going to teach proper hand washing and encourage them to maintain adequate fluid intake and increase their protein intake, and this can assist in wound healing. It can be intensely painful, especially in the perineum area, so we want to manage their pain through analgesics and positioning. A mom can develop a urinary tract infection. This is common during the postpartum period due to the fact that the urethra and the bladder can often be traumatized during labor and birth, and due to the fact that we may be using intermittent catheterization devices. And the pressure of the infant as it passes through the birth canal can cause some issues as well. So bladder and urethra have a loose tone after delivery, and this makes the retention of urine and urinary stasis more common. Signs and symptoms of the UTI would be the frequent and or painful urination, as well as flank pain, and a low-grade fever, and hematuria may also be present. Interventions for this would be treating with antibiotics, encouraging them to drink adequate amounts of fluid to flush out the bacteria. Postpartum depression, again, we talked about is another complication to postpartum period. And again, we talked about how this could be a serious and debilitating depression. And it typically occurs within the first 9 months after the baby's born, but often initially within the first weeks or months, but can last long as well. Signs and symptoms would be the sadness, the crying, the insomnia, the decreased appetite, withdrawal, sometimes suicidal ideations. Clients may present with somatic symptoms such as a headache or diarrhea, constipation, anxiety, feeling as if they're anxious or they're going to jump out of their skin, or not just feeling like themselves. So this is a big difference from just postpartum blues, where you feel a little teary-eyed, a little, you're not confident. So that's a little different. Those are mild symptoms compared to a postpartum depression. And interventions in these cases would be the responsibility of the nurse to assess for this and to call for an assessment with a psychiatric consult. And after screening and assessment, referring the client who's at risk or who's suffering can be referred to an appropriate healthcare provider or for follow-up treatment or therapy. We want to encourage and assist them to reach out to resources in the hospital setting as well as the community. And we want to encourage them to get adequate nutrition, rest, relaxation, and exercise. And that is the end of postpartum complications.